Thank you, Michael. So we'll be anticipating more of your feedback within the hour. Before we can get to our guest this morning, here are a few facts and figures just to share with you to set the basis of our conversation as we gear up for the budget that is being read tomorrow. But right now, we want to focus on the budget, but in relation to health. Take a look at these numbers. This is the budget from the previous years in regards to what was allocated to the Ministry of Health. 2014, 47 billion, 59 billion for the year 2015-2016. The highest we've ever seen, 60 billion, was for the year 2016-2017, which is quite interesting because that's the time the Afya scandal happened, all right? And then it went down, it dipped to about 54 billion in 2017-2018. And now we're waiting for the big one, 2018 to 2019. Now, here's an interesting aspect. All those numbers in their billions still do not meet their budget declaration, which all heads of states, African to be specific, signed back in 2001, saying that at least 15% of all national budgets should go to health. Let's take a look at the second one. Now, this one specifically narrows down to how Kenyans source healthcare. Do you know that 32% of household pockets is how Kenyans source for their healthcare funds and 31% for government or tax? We get 26% from donor contribution and another 13% from health insurance. Anyone who is well-versed within health will tell you that it should be the other way around. Health insurance and government tax should be the highest. And we'll get to hear more from that and why that should be the case from our panelists this morning. Let's take a look at the last one, the last board this morning. Now, the health expenditure predictions. Kindly note that these are predictions from the past 2 years. So it gives you an idea of what Henry Rotich will read tomorrow in regards to the health sector. So free primary health care stands at about 900 million for the past 2 years, 300 million on health insurance for the elderly as well as people living with disability. 4.3 billion, the biggest chunk, went to free maternal health care. So those kind of give you an overall view, a general view of where tomorrow's allocation will be in specific terms of the health allocation. Now, let me introduce you to my panel this morning. Sitting closer to me, Dr. Samuel Kinanjui. He is the country director for AIDS Healthcare Foundation. And closer to him is Mheshimiwa Dr. James Nyikal. He's the member of parliament for Seme. And on my further left is Dr. Samuel Oroko, the chair for KMPDU. Gentlemen, thank you so much for your time. Thank you for being with us this morning. Thank you. Dr. Kinanjui, allow me to start with you. The fact that we've seen that all those numbers are in their billions, yet they do not even come close to the 15% that heads of state back in 2001 met and decided to sign an Abuja declaration. Where are we going wrong, or what is hindering us from us hitting that 15%?
The 15% is important for healthcare, and health financing is important for Kenya. But the challenge that we are facing is, personally, I believe, is the approach we are using to fund the healthcare system. And because if you go down to what NHIF is supposed to do from the Act, you can find out that all of us who are adults, who are above 18 years of age, need to contribute to NHIF, which would help us edge toward that 15% without necessarily having to rely on what the government collects. And I strongly believe that such an implementation of the current NHIF Act as it is, ensuring everybody who is 18 and above, who is engaged in gainful employment, contribute to NHIF. And there are various ways to getting there. The other challenge is that we need to understand that the biggest challenge, as far as I'm concerned, for me, is not entirely the amount of money. It is how we employ the money we have.
Right.
The current situation we have in the country is a situation where we find we are paying and awarding or rewarding healthcare systems that are porous. Why are they porous? Because we are paying for volume, not quality.
And just to add to what Dr. Kinyanjui has said, he's spoken about the issue of quality. You may have noticed that from those statistics, we didn't give you for the year 2012-2013. However, for the year 2012-2013, the expenditure alone was about 243 billion Kenyan shillings, with only 7% that went to improving healthcare. Dr. Okoro, as the chair for NKPDU, Do you agree with what Dr. Kenyan has said, that despite the billions that we are seeing, despite the scandal that we've also seen that rocked the Ministry of Health, the aspect of quality is still not being met, e.g. building of facilities, buying the equipment, etc.?
Thank you. My name is Oroko.
Oroko, Dr. Oroko.
Dr. Oroko. Thank you. I think first let me say that the talk about healthcare in this country has been here for long. And as I said earlier, it's a country we need to move away from the talk and get into the implementation. The allocation to healthcare sector, as it is dismal. That's a fact. Mm-hmm. We cannot emphasize on that. Now, on the utilization of funds allocated to the healthcare sector, there's another story. If you look at the appropriation and how this money is spent, especially at the Ministry of Health, if I may speak, because now we have health as a shared function. We have the county governments taking care of primary health care and county health facilities. We have the national government taking care of the national referral hospitals and the programs and the policy. You look at the money which is given to the Ministry of Health, because I feel that the figures you'll be projecting here is the money retained by the Ministry of Health. If you look at the votes, how this money is distributed, there is a vote on administration. There is a vote on policy and the standards. Administration alone takes about 8 billion Kenyan shillings in the Ministry of Health. And you wonder, what is it being used for? And policy alone takes about 10 billion. When you look at the money left for primary health care and promotion and protection and public health issues, it's about mere 10 billion. So you look at the distribution and the kind of priority which this money is utilized for. A lot of it is used in meetings, traveling, accommodation, meals, for who? For officers who are in affairs or who are going to the field and fueling cars, not to do anything, but to go and sit in a room and discuss about a policy which is never implemented. So I feel, yes, there is a dismal allocation, and on the other side, there is misappropriation of the little which is being allocated.
Dr. James, as a member of parliament, many have said that perhaps taking health to devolution was a big mistake. Should we take it back and retain it to the national level? That way, what Dr. Samuel is talking about is that we will somehow stop all this unnecessary spending within the Ministry of Health.
Let me start about devolution in terms of allocation, as you are saying. The figures you are giving us here is the figures that are remaining at the national government. Now, now some of the money will go down. About 300 billion of the whole over 2 trillion will go down to the counties. And the counties also put money in health, normally about 20 to 30%. The figures are still not very clear as of now. So the money now is divided. There's national government, there's county governments. And the question as to whether we should not have devolved health, personally, I believe that the principle of devolution is correct, and that's the way to go. What problem we have had is the process of devolution. We have not devolved health and all other areas in the way we planned. Remember, we had a transition authority based on the Transition to Devolved Government Act. Now, that is where we missed the point. When health and all other things were devolved at once, it brought a big structural challenge, because these are very complex systems and you can't just change them at once. And so we didn't do the costing of the benefits, we didn't do how we transfer the human resource, we didn't do how we transfer the programs. Some of the programs were donor funded and therefore was linked to complex procurement systems. Now, we didn't go gently, slowly, meticulously and look at that. That is where the problem is. But I think devolving health is a good thing if it's done properly. And let me tell you, I've been in the ministry for long. I was TMS, I was PS there. And what we have now is actually less decentralized than what we had before. I'll give you an example.
Right.
Even before devolution, we had situations where health facilities, which are now level 5 downwards, which are with the counties, they had their finances given directly to them. They had boards that were actually managing those finances, right down to health centers and dispensaries. What has happened? All that now has come back to the county. So it has been less. So my answer is, let us sit down as a country and work carefully and look at the process which we use to devolve. If we do that, we'll be better off. The challenge before, where at the national level, you are also taking care of over 80 hospitals, 4,000 health centers. I think that is difficult. It should be easier now that the ministry only deals with policy and standards, and implementation is left to the county government.
That's the other thing, implementation, because as much as we're seeing these funds in their billions, the other question is the utilization, the accountability. And you believe that for it to stick in devolution and us to properly tap into that, that will then result into accountability, because the Ministry of Health is yet one of the aspects where graft has been seen.
Governance is a big problem in the whole government, in the whole country. And the Ministry of Health is not an exception. So it has also had these problems. And even now, the money that is given this year, this budget, I know it's going to be 90 billion. It is going to be higher than that. You will find that 40 billion is going to go to what are called referral facilities and special services. And this is the money that is going to be used to distribute to the 3 referral facilities, Moi, Kenyatta, and Madari, and also to the other sagas that are within the ministry, that is saying the autonomous government. But look at the 40 billion that is going to special, they're going to special services. A lot of it is going to buy equipment.
Okay.
And a lot of it is going to be given as conditional grants. Again, we then are not devolving properly, because equipment should be bought by the people who are using them at the county. Within that, there's a lot of problems of governance in financial terms. I agree.
Dr. Kinanjui, as the Director for AIDS Healthcare Foundation, we've just seen 26% of comes from donor donation, another 13% comes from health insurance. You want to remember when Donald Trump took office, one of the things that he did was make sure that he pulled funding for AIDS here in Kenya. Talk to the audience about what the risk is for us to be a country that is dependent so heavily on donor funding.
Thank you very much. And I would like, before I tackle that one, to follow up on the question you asked, Mheshimiwa. And it's the issue of why is our health system so inefficient? And our health system in Kenya is no different than all other health systems in the world. And the facts are, the health system business model is deeply flawed. And that's where the problems are. Even with the coming of the Cuban doctors, I wish it's the Cuban system which came to Kenya, because that would help us move forward. If we take anyone, even very good people, even an angel, and put him in a broken system, they will soon be broken.
It won't work.
It won't work. And why is it so? It's because the health system, all health system players, the insurance system, companies, the pharmacies, the pharma industry, the doctors, the hospitals, even clinics, they all make money, they all make profit when you and me and everybody else is sick.
Yes.
So they are motivated to keep us sick for as long as possible. You notice that if a hospital is efficient, I remember during our internship, we went for a locum in a mission hospital, and me and a colleague of mine did a thorough job in one of the wards, and we reduced the number of people who were hospitalized there over a period of 2 or 3 weeks. And soon we were fired because there was no money to pay us. So we are in a system that is designed to keep people sick, because that's the way to make money.
Now,
and that's where the problem is. If we cannot fix that system, and I mean shift it, it's like we are bandaging an old wound or a boil.
So
it will never heal.
When you have a nation that is bound to get sick, that also depends on donor funding, how does that, or what is the risk of that?
Depending on donor is like building on what we can call quicksand. And that building can come down quickly. We remember the story in the Bible where the wise was told he built his house on a rock. When we depend on domestic funding, that is a rock. Depending on donor is building on quicksand, because the donor can unplug the supply pipe any minute and our people can suffer, and there is a great risk. The interesting thing is that with our economy, the situation where we are in, I strongly believe that we shift, improve the business model in the health sector. We are just about there.
Dr. Oroko, as chair for KMPDU, I'd love to hear your thoughts on the Cuban doctors in just a minute. But Dr. Kinyanjui has touched on the issue of insurance. Here's the thing. The likes of Ghana and Rwanda have done so well in achieving or getting a step closer to universal healthcare. Mind you, Ghana was one of the countries that has been stumped before with an economic crunch. But they've somehow made sure that public insurance and the health fund comes from the insurance sector. Why is it important for the insurance companies here in Kenya, be it the NHIF, which is run by the government, or even private sectors, to really up their game?
Thank you. Even countries like Rwanda have done very well in healthcare. The issue here is the cost of healthcare. Actually, there's never been a methodology which is agreed worldwide on how to cost healthcare. In Africa, it's even worse. Because when you do give care to the patients, and this care is not costed, then it's open to fraud. And many insurance companies, as we speak, including NHIF, are going to go under because of the increased fraud in healthcare sector. Many of the procedures which are being done, of course we have the medical board, which has given guideline on how much a given procedure should cost. But then there are no another guideline on how much a drug should cost. So you get paracetamol in one hospital is 20 shillings. In another one, the same paracetamol is 100 shillings. So the best thing we can do as a country, number one, is to come up with a method of costing healthcare so that we have standards and put a minimum and a maximum for each and every procedure, for each and every drug that is given in any hospital, be it private or public. In NHIF, as it is, we need to ensure that it doesn't go down. Number one, the NHIF should be able to compensate more in the public health facilities, because you realize that the amount of money given by NHIF to private is more than the amount of money given to public for the same procedure.
Right. Dr. Oroko, do you feel as if we devote enough money to health governance, to financing administration, and to the health system, more so leave alone to other administrative things like paying off salaries?
More money should go to primary healthcare. We need to invest more money in public health, hygiene, nutrition, so that people are given education. Diseases can be diagnosed earlier. People can be told how to prevent diseases.
Right.
We increase food production, because many people think that healthcare is all about hospitals and the drugs. Healthcare spans across the board. So we need to ensure that the food production is enough, nutrition status is enough. The public health sector need to be improved so that people can go around the country, educate the public on how to eat.
The right way.
In this town, for example, you get many people are in big hotels eating chips, chicken, and they're developing diabetes, pressure. People need to be given education that how to eat to prevent some ailments like diabetes and pressure. Education to the mothers, how to give their children nutritious food, which is balanced diet, to prevent ailments like kwashiorkor and other things like that. So that there are ailments which come as a result of poor nutrition, which we ignore, that is not part of healthcare. And when the complications occur, now we focus on tertiary healthcare. We come with dialysis machines, CT scan to diagnose a stroke because of hypertension. So I feel we need to put more money in primary healthcare.
As a doctor, first and foremost, as a doctor, but also the chair of KMPDU, when you saw a large amount has been allocated to the Cuban doctors who are just 100, and they've gotten even, well, what they've gotten is way more than what KMPDU was asking for. How does that make you feel?
Yeah, the Cuban story we've been saying for long, and I'm seeing that they are being trained. But what we have said as KMPDU and the doctors in this country, we have no problem working with any doctor from anywhere in the world. As doctors, we respect one another all over the world. What we need is the Cuban system, not the Cuban doctor.
Dr. James, as Member of Parliament who is seated here, what are your thoughts when you hear Dr. Oroko saying that, and of course Dr. Kenyan as well agreeing, when we should have borrowed the Cuban system instead of bringing in 100 doctors, which has made us spend even more than what our very own doctors were even asking for?
Let me ask you, let me tell you a simple thing. Even people on the street, even matatu guys, are responsible for our health system failure. Even us sitting
How
here.
so?
Because it's a system. It's the ethos of the nation. In governance, it is how people organize their systems. So if you organize a system that rewards individualism and in a way greed, then that system becomes very difficult to handle public services properly. But having said that, because if you go to Cuba, you also have to look at how all other Cuban systems are working. What is their national ethos? Do you have an issue of graft? Do they have an issue of ethnicity? Will the right people get the right job purely on merit? Now, are people devoted to actually their work? Do people work because they're motivated and they're passionate for their work? Or people work because they're going to get money? The ethos in Kenya is the most you work and you assess you evaluate your success on how much money you have made. That system cannot run healthcare.
But
now, I'll come to that. Now, then he talked about designing a system designed for people to get sick.
Right.
And the donor funding. Really, if you want to look at health, health is a big system. It has many aspects. Financing we're discussing is just one. Then you will have to look at human resource. Then you will have to look at supplies of resources. Then you will have to look at infrastructure, buildings. Then you will have to look at equipment. And then you will have to look at information. Then you will have to look at governance, which does all this. Now, if that governance doesn't work, it is like a body. If one part is not working, the rest of the body will not work. So if the human resource is not working, it won't work. If the supply system is not working, it won't work. If the financial system is working, it won't work. So we need to get all this together. Now, bringing 100 people from Cuba, as doctors, they are welcome. But you are bringing in a system that you have not put together. What we need is to work out a system, starting with our national ethos, and starting with what is the kind of healthcare we wanted.
Dr. Kenyan.
Now, let me just say something. Now, no medical person, I think we are doctors here, is actually happy when somebody is sick because they're going to get money. You actually feel very bad if your patient is not recovering. But what has happened, the system should be designed so that most people are healthy. And that is why we must go for preventive and promotive medicine. You will get primary health care there. You will get all these things. And then curative system takes care of those who, despite our preventive and promotive measures, get sick. So they are fewer. So we'll need little money to take care of them. If you don't do that, then a large number of people are sick, and they are very sick. So you need complex equipment, and you need a lot of money to take care of them.
Okay, so the system is the biggest thing that is in question
Yes,
here,
it's the
despite
biggest
the
issue.
allocations of billions in the Ministry of Health. Dr. Kenyan, then even ahead of the budget reading tomorrow, what role does the private sector, because we talked a lot about the government, what role does the private sector have to play in making sure as Kenya we attain universal health care?
Oh, thank you very much. I would like to follow in the vein of my senior colleague here, Dr. Chikal, in terms of looking at the health as an ecosystem. And when we look at health as an ecosystem, private sector is just a player, one of the players in this arena. And as Achinua Chebe said, when the center does not hold, things just fly out, they fall apart. And that's what is happening in the health sector. The issue of governance. But this issue of governance needs to have a business model. There are practically about 4 types of business models in the health sector. The UK one that you find that the UK have one of them that use the national health system, where we borrowed the issue of NHIF. We have it's called the beverage model. Then we have the one that works in Germany. And in the US, it's mainly private sector. In Africa and in Kenya, we actually have no system. So we have a combination, is chaos. And we do not, if a system does not have a guiding rules that guide how, you can imagine having a game where the referee also happens to be the coach of one of the players, of the games that are team that's playing the game. What's the chance that the other team can ever win? And in the ecosystem that we have in healthcare, it so happens that the patient is the player in this game where the health system players are both the coach and the opponent. So the key things that we need to look at is that we design the health system as any other industry, for example, manufacturing and so on, where the value to the patient is the key thing. What is the value to the patient? It is the outcome that matters most to the patient.
I'm glad you brought the aspect of value, because that's one thing I will... Would you want to finish?
Yes, I'd like to finish. The issue of value is that when I, as a patient, when a patient walks into a health facility, what do they want? They just want to get well and get back to doing their business at the lowest cost possible. However, we're in a situation where, for example, if any of you remembers ever seeing a bill from a hospital right now, is that the bill will have every little thing that was done to you. For example, if you go to a hotel and you're told the tea contains this amount of sugar, was boiled for this amount of time. Now you are billed for everything, including the water that was spilled, a cup that could have broken in the kitchen. That's what is happening. And as a result, the healthcare system is incentivized to be wasteful at the way it stands right now. If we were to set the system and say, I follow what Dr. Rocco said, a question of saying, for each of these services, this is the amount of money the payer will pay you to deliver. Let me give you a succinct example on the free maternity. Before the free maternity, our cesarean section rate was anything between 15 and 20%. Right now, if my numbers are right, we are past 50%. Why? Because the hospitals are incentivized to do more cesarean sections because that brings in more money. If I was to reverse this situation, I would say, let's pay, instead of paying 21,000 for a cesarean section, let's pay 10 or 11,000 for delivery. Whether the delivery is a cesarean section or the delivery is a normal delivery, then you'll see that the numbers will come down to the normal.
All right, Dr. Roka, I'd love to get the last, I want you to have the last word, and probably in about 30 seconds because of time. When the Constitution says that we need to attain the highest attainable standard of health, what does that look like for a common Kenyan?
Thank you. Before that, I would like to say that for allocation of resources to healthcare, the current system of looking at the different wards in terms of administration, policy, we need to change and use the health system pillars. Look at human resource, allocate for that. Look at governance, allocate for that. Medical supplies, health information management system, so that we look at the pillars and allocate on that area. Right. But in terms of attaining the highest health care in this country, it is still the responsibility of the state. To do that, I still insist, we need to focus more on primary health care. The community health care workers need to be brought on board. We need to ensure that we map out all our households in the country and be able to know in each household what kind of ailment is suffered there, and have data and convert it into information for use, so that then we are able to plan for the people who we know what kind of ailment they have.
All right, thank you.
It's difficult to plan for what you don't know.
All right, thank you so much, Dr. Oroko. Gentlemen, thank you so much for your time this morning and helping us look into that. Of course, we'll be keeping an eye on the budget and more so on the health sector tomorrow as Henry Rotich prepares to read the budget. Of course, that was Dr. Samuel Oroko, who is the chair of KMPDU, and sitting closer to me is Dr. Samuel Kinanjui, the country director of AIDS Health Foundation. And in the middle is Mheshimiwa Dr. James Nyakal, Member of Parliament for Semen. Michael?
All right, thank you very much, Zinzi, on that very incisive interview and basically just getting information. And of course, for many Kenyans, well, the question is whether universal health care remains a pipe dream or it can actually become a reality. And of course, one of the areas that's going to indicate that is the budget, is what is going to be read tomorrow. So all eyes on the budget tomorrow, apart from World Cup. But because of time, we'll have to wind it up right there. So Morning Express says goodbye, but do stay with us right here on KTN News. Betty Kialo takes over the reins and News Center begins with more news and reviews from us right here on Morning Express. We say goodbye. Have yourselves a good day. God bless.